Friends, as all of you are aware, the South Asia communities of practice has been mainly focusing on maternal neonatal health issues in sync with the WHO CRO directive of focusing on the maternal neonatal health quality concerns. But the recent Lancet Quality Commission, if we look at the details of the Quality Commission's report, we find that the largest number of lives are lost in not the maternal neonatal health domain, but in cardiac clinical practice. And these are the lives which are lost because of quality care concerns and because of lack of access to high quality cardiac care. Well, we thought that this is a high time that NQOCN focuses on the quality and the patient safety issues in the month of International Patient Safety Day on quality of care concerns in day-to-day cardiac practice. We started the session last month by a very successful session with Dr. Poonam Gupta, and we are indeed indebted to her for conducting the session on role of value improvement in clinical cardiac practice. And we follow up this today with a very practical session from none other than the very eminent Professor Mohan Nair and Miss Julie Simon from the Holy Family Hospital, New Delhi. So I will just very briefly introduce the very eminent panel which we have today for the clinical discussions. We are starting with our first guest speaker. Our guest speaker, Professor Mohan Nair, does not need any introduction here. Professor Nair is the coordinator and head of the Department of Cardiology at the Holy Family Hospital, New Delhi. Sir is a visiting faculty at the Massachusetts General Hospital, Harvard Medical School, Boston, USA, and has been previously the professor of cardiology at GB Pant Hospital and Maulana Azad Medical College, University of Delhi. Currently, sir is an adjunct professor of cardiology at ESIC Medical College, NCR, Delhi. He's been the chairman and director of cardiology at Max Hospitals, New Delhi, and has been invited to almost all major hospitals across India, as well as Sri Lanka, Pakistan, China, Nepal, to conduct hands-on teaching workshops and complex cardiac procedures. Sir has been inducted as an honorary fellow of Ceylon Association of Physicians and conferred a lifetime professor of cardiology title at the University of Lahore, Pakistan. Sir has been awarded a Lifetime Achievement Award by Prince Albert II, the Monarch of Monaco, and has received several awards and orations from the Cardiological Society of India and the Indian Medical Association. Welcome, Professor Mohan Nair, to this session on day-to-day concerns in patient safety and quality in cardiac practice. Our next speaker for today is Ms. Julie Simon. Ms. Julie Simon is a cardiology lead nurse at the Holy Family Hospital and works closely with Professor Mohan Nair and his team. She has more than 8 years of experience in intensive care unit and 2 years experience in cardiac cath lab. Her special responsibilities include ensuring quality standards that are in compliance with the NABH standards, training of all the new recruits to cardiology in special procedures and compliance, and conducting audits on period basis and SOS on issues related to quality and outcome measures. Well, I think Ms. Julie is going to be talking about the practical aspects, which will be of great relevance to the large number of nursing colleagues who are a member of the communities of practice today. Welcome, Ms. Julie, to this session. I'm also very pleased to welcome the very eminent panel here we have today for a short discussion post the sessions with the keynote speakers. And the panel consists of none other than Professor M. Khalilullah. Sir is a renowned and experienced cardiologist with more than 58 years of experience. Sir is a recipient of Padam Shri as well as Padam Bhushan. Sir has been awarded the BC Roy National Award and the Rajiv Gandhi Excellence Award for Lifetime Achievement in Cardiology. Currently, Professor Khalilullah is a senior consultant at the Heart Center, New Delhi. Sir has made multiple innovations in the advancement in the field of cardiology and has established the epicardial mapping and the surgery for Wolff-Parkinson-White syndrome technique for the first time in Asia. Professor Khalilullah has introduced various investigations and treatment protocols of heart diseases for the first time in the country, and his work has directly resulted in saving millions of lives across the Indian subcontinent. Welcome, sir, to this Communities of Practice session. Indeed, we are very pleased to have you here, and it has been a great honor to have you here on board. Next in the panel, we have Dr. Aparna Jaiswal. Welcome, Dr. Aparna Jaiswal. Dr. Aparna Jaiswal is a Director of Cardiology at the Fortis Escorts Heart Institute, New Delhi. Dr. Aparna's areas of interest include implantation of cardiac devices and ablation of arrhythmias, especially ventricular arrhythmias, which can be life-threatening, and management of heart failure and atrial fibrillation. She has mentored numerous electrophysiologists for the past several years, and she is a board member of IBHRE USA and a trained professional in electrophysiology at St. Luke's Medical Center, Milwaukee, and further certified with IBHRE as a device specialist. Welcome, Dr. Aparna, to this Communities of Practice session. We're also pleased to welcome with us Dr. Vishal Rastogi. Dr. Vishal Rastogi is the Additional Director of Cardiac Sciences at Fortis Escorts Heart Institute, New Delhi. Dr. Vishal is a pioneer in the field of interventional heart failure management and has got one of the largest Indian experiences in implanting Impella left ventricular assist device. Dr. Vishal has a vast experience of complex coronary interventions, including rotablation, carotid intervention, peripheral vascular interventions, and percutaneous aortic valve implantation. Dr. Vishal is actively involved in the ECMO program and the LV assist device and the cardiac transplantation program of the Escorts Heart Institute, New Delhi. And he serves as a national proctor for rotablation, coronary imaging like IVUS, and OCT for the dedicated bifurcation stents. Welcome, Dr. Vishal, to this Communities of Practice session. Indeed, we would be very eager to hear from your rich experience. And lastly, last not but the least, we have a very famous personality. I'm sure most of you have seen him on the television, conducting lots of spiritual sessions. So we have none other than Professor Mohit Gupta, and I will start with giving his introduction in reverse order. Dr. Mohit Gupta is associated with the Brahmakumari's World Spiritual University since more than 36 years. And he has achieved a great blend of spirituality and modern medicine in his day-to-day cardiac practice. He is currently the Professor of Cardiology in GB Pant Hospital and Medical Superintendent of Cardiac Sciences and a cardiologist at the Parliament Health NXC. He's a Fellow of the American College of Cardiology, European Society of Cardiology, and the Cardiological Society of India, and the Fellow of the Royal College of Physicians at Edinburgh. He is recipient of the prestigious D.P. Basu Memorial Award for the Young Scientist of the Year by Cardiology Society of India, and he's been awarded by the Honorable Health Minister of India an Excellence in Cardiology Award, and also awarded the Bishan Swaroop Young Scientist of the Year Award by the Honorable Vice President of India. Welcome, Dr. Mohit Gupta. And without further ado, I now call upon Professor Mohan Nair, sir, to start the session formally. The screen is all yours, sir. You can start the screen share now. Thank you so much, sir. So we'll have to unmute yourself. Yeah. Nair, sir, you will have to unmute yourself, sir.
Thanks a lot for the organizers of this meeting, particularly Vikram, who's been a friend for a long time. For some reason, I find that Dr. Kaliula is left, but he is the, if whatever I am today, most of it is because of what I learned from.
So you have to sign out from one of the screens. You're logged in at two screens. That's why the voice is echoing. So you have to sign out from the one of the screens. You're logged as two IDs. That's why the voice is echoing.
No, but it is the same ID. Now you can hear? Oh, I think that, okay, I'll just switch this off.
So that's fine, I fixed it. You can go ahead, sir.
No, it's okay. I thought that.
Yeah, that's fine, sir. So please go ahead, sir.
Yeah, no, I'll do it from the same, we'll do it from the same laptop. me and Julie. I haven't really made slides because Julie will have the slides. As far as I'm concerned, cardiology consists, especially in terms of safety and patient outcomes, into two different. Before that, I must say that on one hand, Dr. Khaliullah has been my idol, mentor, and I wouldn't have been what I am if but for Dr. Khaliullah and his contribution to cardiology is immense. I had done an interview a few months back on his lifespan, life, and I cannot tell you how impressed people were. There were 4,000 people who had logged in, and from where he started and where he ended is a truly amazing experience. The others are all actually my students or friends. So that's yeah. Sir, welcome back. I was just saying that I wouldn't have been what I am but for you. And I just can't express in words how grateful I am. In fact, I'm almost choking while saying this. So I was telling them that I've done an interview with you and how impressive that interview was about your, life from childhood to becoming a doctor and establishing GB Pand and so many innovations. And let me tell you, we are all directors of intervention cardiology, doing all kinds of angioplasty and everything. But we wouldn't have been here. We would have been at least 10 years behind. And my CV said that I had gone to China to teach them angioplasty. All that would not have been possible, but for the initiative taken by Dr. Khaliullah. He did the first Hughes bundles study in India. He did the first catheter ablation. He did the first balloon angioplasty. He did started the first angioplasty program. And of course, is the first indigenous pacemaker. So there is nothing really left. And it's really an honor to have you as a panel. And somewhat of a paradox, but a pleasurable paradox. On the other side are people who have been my students or, my student level. Aparna I have known for a long time. She's again a very knowledgeable person, speaks very well, speaks extremely well actually. I love to hear her talks, and she's really balanced, it's unlike some other people. Vishal is looking different. The last time I saw Vishal, he looked like a school student, and I think he's put on a French beard and done something. I don't know what he has done. And Mohit, of course, sends me messages on spirituality, etc. And he again is a very, very wonderful speaker, be it cardiology or spirituality. And I do try and listen to his. I need a lot of spiritual. I need a lot of spiritual knowledge, because I'm a wayward guy. So to put me online, I mean, people like. And once again, I can't thank Vikram. I've known for such a long time, and he's put up on this whole show. So when I see this, I think cardiology, when you look at safety and outcome, there are two parts. One is the procedure. Now, the procedure can go from temporary pacing to angioplasty to valve replacement to cardiac transplants. And these procedures are dependent on a lot of things, including the team skill set, the team's experience, the equipment available to you, the infrastructure, all those things. So I don't think I should be speaking in this forum about those things. That's very specific, and you can't even cover one topic in this time. The other side, which I think, I don't know whether Professor Kalula will agree with me, is equally, if not more important, is the care part. The care that you give before, during, and after the procedures. And that's something that requires a lot of thinking, learning each day. And we still have, I think, a poster outside our cath lab saying that we are a Six Sigma cath lab, cardiology, which means that at each step we try to see that a second mistake, the chance of a second mistake is less than 1.34 million times. It's not necessary, but it's just written so that the new girls come. Some of them have not even heard of Six Sigma, but when they see that, then they go back, read, and try to, come to those standards. So some of these things, Julie will discuss. And I was thinking whether questions could be asked in between by the moderators, but as Vikram rightly said, that let Julie finish her presentation, and then we'll have a composite, discussion on all aspects, if that's okay with everybody else. Now, Julie herself is a person with more than 10 years of intensive care experience. She is very nervous speaking in front of so many senior doctors, so you must give her that much of leeway and apologize the small mistakes that she might make. But I think one thing why I chose her, I could have chosen the nursing superintendent also, but while I chose her was because she has very intense involvement with cardiology and is an extremely hard worker. So she works very, very hard, and she's been working non-stop ever since I gave her this assignment. And so even if by Aparna's standards, she doesn't come very high, I'm sure she'll make a good presentation. And after that, we can have a composite discussion. So over to you, Julie.
May I come in before she starts, since you made a mention?
Yeah.
The very fact that Julie is here to present in itself is an honor and pride for all of us. So keep it up, Julie, and you'll go shining through.
Thank you, ma'am.
So we share the screen. This is the one, this is the one. So I'll just go to the last slide. Can you all see see Julie's slides?
Yes, sir, we can. Exactly.
She was even while we were doing all the introduction, she was rehearsing. So we were on the last slide. Go.
Good evening to all respected seniors and colleagues present in this session. I'm extremely thankful to the organizing committee, particularly Professor Vikram Datta, for giving me the honor of presenting this topic, patient safety and quality of care in day-to-day cardiology practice. As we all are very familiar about this topic, As we know that cardiac patients are generally very ill, they tread a thin line between life and death, and patients have a high incidence of comorbidities such as diabetes, kidney disorders, etc. Many are classified in the group of immune compromised patients. Because of the above, they require very focused care with near zero error levels. When I talk about the zero error levels, it can be adverse healthcare event during hospitalization, drug reaction, sentinel events, or medication errors. The term safety, I have elaborated it. S, it stands for sense of error. A, act to prevent it. F, follows safety guidelines. E, inquire into accidents or incidents. T, take appropriate remedial measures. And Y, you are responsible. As we can see that whenever there is some mistakes or error, we just find it out and act properly according to the hospital protocols, and we go through the accidents or incidents, what has happened, and we take appropriate measures. So it is not only the responsibility of the nurses, but it's the whole healthcare team, those who are taking care of the patient. It's the responsibility of each and every person. There are certain principles for maintaining patient safety and quality of care, like strict monitoring of hemodynamics, avoiding hospital-acquired infection, proper nutrition, specific care related to comorbidities, high level of communication that can be between team members, between patient and caregiver. Special training over and above general nursing and ICU care is being taught to the nurses. Periodic audit of outcome measures are done. Root cause analysis of any adverse event is checked. These were the list of the principles, but now I'm going to explain each and every principle in detail. Maintaining hemodynamics. When we are dealing with the hemodynamics, it is critically ill patient requires continuous assessment of their cardiovascular performance. This is most commonly achieved by astute hemodynamic monitoring, which includes heart rate, ECG, blood pressure. Blood pressure can be invasive and non-invasive, and SpO2 monitoring. All staffs are properly trained in operating these monitoring devices and proactively address hemodynamic crisis safely and effectively. Any adverse event is escalated to the next level of care as per specific protocol need. And another aspect of the principle is avoiding hospital-acquired infections. Hospital-acquired infections are a major cause of mortality and morbidity and provide challenge to clinicians. Measures of infection control includes identifying patients at risk of nosocomial infection, observing hand hygiene, and avoiding urinary catheterization unless absolutely necessary. In our hospital setup, we prevent hospital-acquired infection by following proper spacing between the beds, maintaining staff-patient ratio, and safe disposal of waste. We are also using certain bundles like WAP, CLEP-C, COTI, SSI bundles in our files. Proper nutrition. In hospitalized patient, it is very necessary for wound healing, recovery, reduction in morbidity, and consequently reduction in the length of stay. The nurses in the CCU, they identify the food preferences of the patient and also give diet charts at the time of discharge. We also arrange appointments with the dietitian to know more about the diet which they have to take properly. Patients are also educated about a healthy diet and promote healthy eating habits through their conversation with patients and families and through their work providing enteral and parenteral feeding to critically ill patients. There are certain specific cares related to comorbidities. What the nurses do? The nurses collect the information regarding any existing comorbidities from patient and family by taking history or any surgery, any reports or records are collected from the relatives and the patients. Critical reports are immediately informed to clinicians and emergency management is done. Like if we are sending some blood investigations, we find out that patient is having deranged kidney function, then we are informing to the doctors immediately. And if they need some other high level requirement, like they need to consult a nephrologist, then we consult them. Like multi-specialty team approach is used in all patients, even if the comorbidity is initially labeled as trivial or under control. Communication is one of the most important aspects of the principle. Each nurse speaks to the patient for at least 15 minutes, a minimum of 2 times during each shift. By communication, we assess the comfort level of the patient and it is recorded, and we identify the discomforts or concerns of the patient. After the treatment given, we assess the improvement parameters are as has achieved or not. We also check through communication. In case of any deviation in any of the above, a SOP is used to address, correct any anomaly. Communication is done in a manner and a language that the patient is most comfortable with. Training. All nurses allotted to cardiology receive a special orientation course in cardiac care. Only nurses with CCU experiences are posted in the cardiac catheterization lab. Timely in-service education program is done for the nurses to update their knowledge and skill. Audit. The outcome and effectiveness of treatment provided is evaluated through audit. The number of are checked every month. In patients who develop any serious adverse event, a root cause analysis is done. I would like to inform that the discharge rate with full neurological recovery in our patients who are intubated in the emergency is nearly 70%. There are certain special situations in which the nurses take care of the patient, like acute myocardial infarction. In this condition, we know that they need primary angioplasty. When like this type of patient comes, the cath lab team is activated as soon as the patient arrives in the emergency department through dedicated emergency cloud network, so that the door to balloon time should not exceed 90 minutes. The emergency angioplasty team consists of minimum of 2 consultants, 2 senior cath lab nurses, and 2 technicians. All hemodynamic support systems such as IABP and ECMO are kept ready for use if required. The other condition is heart failure. What does the nurse do when a patient comes with a heart failure? The key interventions are: she maintains the fluid balance, monitor the weight charting, inotropes and diuretics are given, renal function and electrolytes are monitored, and if there is some deranged renal function test and the patient needs dialysis, the CCU is equipped with 3 beds that are dialysis enabled. These are used for excess fluid removal and maintaining electrolyte balance in resistant heart failure cases. If required, veno-atrial ECMO is also used. There is a tie-up with networked hospitals for left ventricular assist device and cardiac transplantation. Certain specific care is needed while the patients get admitted for the cardiac implantable electrical devices like pacemaker, AICD, and CRT. Preoperative preparation, which we do as a nurses, like surgical site preparation is done. That is done with betadine 10% twice. Then we give prophylactic antibiotics, which is given half an hour before and 6 hours after the surgery. Non-reflecting UV rays are used. This helps us to use the UV light both before and during the procedure. The UV we are using is shown in this picture. It is the device pocket is not closed unless complete hemostasis has been achieved to the satisfaction of entire team. Swab culture of the cath lab is tested every 6 months. These protocols have helped us keep device infection rate to 0 in the past 6 years. The type of UV which we are using is that far UVC lighting is an autonomous and continuous disinfection system for occupied spaces. Traditionally, workers are required to manually wipe down the surfaces, leaving the room for mist areas and the inability to sanitize against airborne pathogens. This FAR UVC is a non-invasive sterilization solution for public areas that eliminate both surface airborne bacteria and viruses, including SARS-CoV-2. It is safe for both patients and the healthcare workers. Post-operative care, which we do for the implantable cardiac devices patient. Pressure bandages for 48 hours to prevent hematoma. ECG and X-ray are done immediately on transfer to the patient bed to document the correct lead position and look for pneumothorax. The same is repeated next day and if the patient develops any symptoms. Mobilization of the patient is done within 6 hours. Then special care of the joint and mobilization instructions are given during the time of discharge to prevent the frozen shoulders. Now I would like to summarize my topic. Improving cardiac care and patient outcome involves special standard operating procedure for each type of procedure and patient admitted in cardiology. Nurses need extra skill sets, strict auditing of outcomes at regular intervals, and high level of coordination and communication between team members. Thank you.
Big round of applause for Ms. Julie Simon for very crisply and very lucidly presenting the protocols in the CCU, which have resulted in absolutely zero, close to zero infection rates for the last 6 years. In fact, that is noteworthy in such a busy hospital setting to achieve that in a warm, temperate climate with such high patient load. In fact, there's a lot of lessons for the teams across the country to learn. And I'm sure the participants who have attended today will take home a lot of messages. So I request all the participants to take a note that the question and answer sessions will be open and we'll not end the session until all the questions are answered. So you can please post your question and answers either in the chat box with your name, with your comments, or in the Q&A. And we will be addressing the questions directly to Professor Nair and the eminent panelists and to Ms. Julie as well at the post part of the concluding part of this session. So with this, I have, with the permission of Professor Mohan Nair, sir, I will now start inviting comments from the very eminent panel we have here. And first, I have, thank you so much, sir. So first, I have the pleasure of inviting Professor M. Khalilullah, sir. Professor Khalilullah, sir, I would like to invite you here and listen to your perspective on the evolution of quality of care and patient safety over the last 4 to 5 decades of the clinical practice of cardiology in India. We know, sir, that you have been an innovator and you have been a pioneer of innovating with multiple techniques of cardiology, non-invasive cardiology in the country. And we look forward to hearing from you how quality and patient safety concerns have evolved, how they were present earlier, and what is the status right now, and what is the future which you look forward, or any other comment which you would like to make on the presentation or any guidance, sir. Over to you, sir.
Thank you, Vikram, for inviting me to be a panelist on this very important issue. And I'm very happy to see all my students and great cardiologists on the panel who have joined me on this issue. See, my involvement in patient care is for the last 60 years, more than 60 years. When I became a doctor in 1960 and became an intern house physician, there was no concept of critical care. Patient is to be all part of general ward, and we used to look after the patients to the best of our ability with the help of some trained nurses. Keep watching on the pulse rate without putting finger on the wrist of the patient. There was no monitor available. There has to be a ECG machine. We sometimes give a shock from the veins from time to time. From then onward, I have seen the whole progress in patient care. I shifted to All Institute of Medical Sciences in 1966 when the cardiology was really at its peak. And I was trained. I'm grateful to my professor and chief, late Dr. Sujay Roy, who trained us into whatever we are today. And we had the pleasure and privilege of training many of students, a very eminent cardiologist today, like Dr. Mohan Nair. When I started doing intensive care in the institute, there used to be 4 beds. I started in a room, and there used to be a single defibrillator, which was very heavy to pick up. So once it so happened that the patient became suddenly unconscious, and I could see on the pulse there was nothing available, and we had defibrillator on the 2nd floor, and we very strong intern by name Dr. Gujral. He was almost a bodybuilder. So I said, get the defibrillator quickly. So I picked up the defibrillator, brought it down 2 floors down to shock the patient, bring him out. And then we found that patient has got heart block and going into repeated BT and BF. And the first pacemaker was implanted in 1966 at the AIMS in a patient who came from Jorhat, Assam. He was a pediatrician by name Mohit Gupta. When he came from Calcutta to Delhi airport, I was deputed as a resident in cardiology to go and bring him to the hospital. And I had nothing but my fingers on his wrist to watch his pulse rate like. And I had 2 syringes of atropine and adrenaline in my pocket to shift him from the airport to the hospital. And this is how the whole thing started slowly. Then we used to round the clock, look after the patient, all the residents, and nurses were slowly trained. They didn't know what is intensive care. They didn't know even in fact cardiology care. So all this was started, and I must say Dr. Roy's vision was great. He had started this program and started involving the nurses, nursing staff slowly, and we should teach them ECG, we should teach monitoring. There was nothing of this kind available. I shifted from AIMS to GB Pant Hospital in 1971, December, and we established first coronary care unit in GB Pant Hospital in 1972. 6-bedded ICU with a central monitor. And I used to be always very critical because I had gone from AIMS to GB Pant. And one day I made a comment on a patient who came in the night and was not given a temporary pacing the night. The next morning she died. So I commented in the presence of Dr. Padmavati that, madam, we are practicing 19th century cardiology. So she said the remark is very cryptic. So she said, all right, put him the CCU in charge. So I put him I was put in the CCU as a punishment. But I took this opportunity to build it up. I used to be around this CCU about 18, 20 hours a day, looking after everything around, training my residents, and starting a new things there. We had a Philips system of monitoring system where the pulse blood pressure was recorded. In fact, there was no method of recording blood pressure and SpO2 those days, except the pulse rate and rhythm. And I could always get into the CCU to find something new is happening with the resident had missed. I think this is the effect of constantly watching the monitor. You get slightly brainwashed, and the patient having VT or certainly the rate has got down. So one could see those things happening there. With that, we started building up. The cath lab was already there. We started the whole cath lab. And there we didn't have trained staff. There was a gentleman, Mr. Bali, very old gentleman who was looking after the cath lab. And the cath lab was operated 3 times a week. They'll do 3-4 cats in a week. And the cath lab was in charge of the radiologist, not the cardiologist. So when I had a 1-year stint in Pune as a chief of cardiology, and I used to do about 3-4 cats every day. So when I came to GB, I found remarkable difference in the whole thing. So I slowly shifted Mr. Bali to an air-conditioned room to look after the stores and trained 2 orderlies, Jagdish and Mohan Nair. And they got trained so much that one point in time, a visiting professor from America said that we can pick up the gentleman anytime to take him to America. So that was the part of training, but all training depends upon enthusiasm, intellect, and interest of the person. And that's how the whole thing started. Then our resident staff started getting trained in treatment of arrhythmias, use of defibrillator, use of agents. And then we started mobile care units. One first ambulance was picked up. It was fitted with all gadgetry, including the monitor, and we are trying to get even wireless monitoring system to GB Pant Hospital from the patient doorstep to the intensive care unit. So this started a mobile care unit. So all this concept of mobile care unit, streptocardial started as a thrombolytic agent. Then we started cardiac pacing. There was to be one pacemaker, two pacemaker implantation in a year in GB Pant. When I left there, they used to do 12 or 15 in a month. So that's how the whole thing is started. The interest into the field of cardiac pacing, electrophysiology have to be cultivated. Everybody is not interested in it because less mathematics. Either you understand or you don't understand. But this is a teamwork. Technical support from the technicians, nursing staff from the nursing group, and your supervision, constant supervision, constant encouragement to them, constant training and updating from time to time. And that's how I realized that now you have monitoring system available where you can see the blood pressure, and don't rely on the blood pressure all the time. You always cross-check minimal blood pressure, whether it's telling or not, because the cuff may be different for different patient. If the patient's a large arm, as a heat fat patient, it may record a lower blood pressure than the true blood pressure. And the same thing about the pulse rates, Sometimes the 50 cycle disturbance comes, you get the wrong reading. So always cross it from time to time. I have now become paranoid about the care of the patient in such a manner that the treatment chart in which to have every half an hour record, I modified to a 5 minutes record. So you are always kept awake. You can't go to sleep if you record the system every 5 minutes. And the arrhythmia, the use of defibrillator, monitor, hemodynamic monitoring, all this has to be taught and trained. Unfortunately, in our country, this area has been neglected for a very long period of time. Slowly we're building up. There are young boys and girls who are getting interested, and they have intellect enough to be trained for this. So I think all this evolved over a period of time. Today you have everything on the fingertip. You have everything on the scope which you can go on to. But there are 2 or 3 things I must keep in mind. That number one, it requires 3 factors in patient care. One is dedication. If you don't have dedication, you're not fit to work in the CCU or to look after cardiac patient. Number 2, the knowledge. Knowledge has to be inculcated, has to be acquired, has to be learned, by giving them books on ECG, patient care, on cardiology care, cath lab, etc. And then the last is skill. The skill is not everybody's cup of tea. Some people get skill very fast, very quickly. There are some people that don't. So you have to ensure that the skill is cultivated in them, and they have one they can do an arterial puncture to get blood gases. All this has to be trained and ensure that they are doing properly. The preventive infection has been talked about. We have to ensure that there is proper ventilation. The traffic patients' relation from time to time has also been curtailed, and ensure that people go put on a gown and have a mask and cap before they get into the coronary care intensive care unit. So all this has evolved in a remarkable period of time, over a period of time in a remarkable manner. And it's a dream come true that what I've seen today was not even conjectured over 50, 60 years ago. So I think I must say that it's a teamwork between the medical personnel, between doctors, between the resident staff, between the technical staff, between the nursing staff. All this combined together, it can make a difference in life and death. Many times I've seen a patient who is so sick that you won't expect him to develop the next morning, and he's sitting and having his breakfast. This is all gift of life, and all this is possible by teamwork of the doctors, the nursing staff, and the technical staff. Thank you, Vikram, for inviting me. I think I've gone too long. If there are any other questions, I'll be very happy to answer.
Thank you so much, sir. In fact, hearing you has been entirely inspirational, and it's been an eye-opener for all of us. Retracing your journey of over 6 decades into the practice of evolution of cardiology, sir. In fact, I think our teams of NQOCN and the South Asia communities of practice would indeed be very grateful to you. And in fact, like you very rightly mentioned, sir, there are a host of factors, dedication, skill, and knowledge. But on top of it, sir, I think it depends the leadership and the accountability which the leadership provides. And sir, in
Sure.
your case, we've heard from Professor Nair. It was, I think, the main driving force for whatever our country is seeing today has been because of the leaders like you and the leaders who have inculcated the high level of patient safety and quality concerns in the health system. And that is why, sir, we can see all your students who are here and the people who've been closely associated with you, the level of cardiac critical care in our country. And I myself have personally been a witness to the cardiac critical care in our country. And the entire team which is sitting, some of them know the stories quite well. This is not the forum to discuss it, but I can vouch, sir, the highest quality of care is being provided. And still miles to go, but definitely this is the right platform. But a lot has happened entirely because of leadership and the commitment which you have provided from the highest levels of care in clinical cardiology. So thank you so much, sir. Sir, please stay back. And we will be coming back.
Before we go, can I make a comment?
Yes, sir. Mohan Nair, sir. Please go
When
ahead.
I joined cardiology, I was quite casual. I mean, it was just one of those things. So Dr. Karula said, actually said that you work like a daily laborer. So inside me, I said, I'm happy, going in the morning, getting my wages and going back. So it's a great change that the daily laborer today is addressed me as an eminent cardiologist.
Thank you so much, sir. I think this served as a great nostalgia for you and also for many of the people who are around. And sir, we will next, with your permission, we are going to move next to Dr. Aparna Jaiswal. Dr. Aparna, ma'am, we would like to hear from you, from your experience in working in one of the most busiest corporate hospitals and leading the electropacing department there and dealing with very sick patients. Ma'am, you have experienced right from your academic time to the shift to the corporate culture. You have experienced a lot of improvements in quality of care, improvements in technologies, lots of expectations rising from the patients, a lot of accountability coming forward. Can you just recount any specific instances of where there were significant quality concerns and how your team has now standardized those processes and your team delivers high quality care in midst of challenging times like the current pandemic times, ma'am? Over to you, ma'am.
At the outset, I'd like to thank Dr. Vikram for giving me this opportunity and Dr. Mohan Nair for having extended the invite. And Julie, of course, did a splendid job at the presentation. And the highlight, I think, was what she reinforced was the teamwork. So going on from here and where Dr. Khalilullah sir left, I think the couple of things which he said, I want to reiterate: dedication, skill, knowledge, intellect, intelligence, hard work, all of this, I think we all have to encompass at the very outset when we consider ourselves going into clinical cardiology or, for that matter, any sphere of medicine. So moving from there, I think the most important is a couple of points which I'd like to highlight as to what we do in our practices. But I would like to make a point here that there is no distinction when you're dealing with a corporate hospital or a government hospital, because you're dealing with human life at the end of the day. And I think all of us follow the same practices. So there is no other difference between the two. And we have to keep that in our heads because it's human life that we're dealing with. So what we have done to make our practices improvised, considering, yes, we have a high volume with several of us working together in the EP department, led by my superior, Dr. Anil Saxena, whom I'm very grateful for having mentored all of us in the department. So what we've done to make the practice better and better outcomes, we have a WhatsApp group. Before we go into the procedures, all of us know what we are heading on for the next day. The patient data is all filled in there the previous night. So we know what the patient's heart pressures are, what are the patient's counts, what's the patient's creatinine, GFRs before we go in. But what I want to talk about, the most important thing is where even Dr. Khalilullah made a mention, was a sick patients that we deal with, and especially when we're implanting devices in these sick patients, it is not a surprise that we would have ventricular tachycardias and ventricular fibrillation on the cath lab table. The accountability and responsibility lies in the hands of the operator, which needs to be shared with all the people in the lab. So what we make sure is that we have a defibrillator, and it is recommended that you must have at least 2 working defibrillators. Having said that, it does not end there, and I'm sure Dr. Mohan Nair will agree. We have several techs working in the labs. The commitment of a technician has to be immense, because when the operator is on the patient's side operating on the device, we certainly cannot go and offer the defibrillation or a cardioversion. This is a fear which I hold, having burnt my fingers. So before I start the case, and while I'm wearing the gown, and this is a protocol that we follow in our lab, irrespective of how trained the technician may be, we ask him to come to the defibrillator side and dummy a cardioversion or dummy a defibrillation on the patient, so that we are sure that if we were to do so, there would be no loss of time, because this, as an electrophysiologist, be it an EP procedure or be it an implantation of a device, is most vital, because you cannot lose a life on the table. I'm sure Dr. Mohan Nair sir will have something to speak of this. So that was one thing which I wanted to talk about. The second, what Julie said, I want to take forward is infections. For any successful program to run in the country or in the world, we need to have the least infection rates. And it is so encouraging to hear that they have had 0 infection rates. Must be very stringent practices. To add on to what we also do similarly is we take random hand samples. So we have the microbiology team come in, be it a nurse, be it our fellow, we have random sampling. Also, when we do our procedures, we make it a point that we change our gloves during the procedure, all of us, at least 2 times. Before we touch the device and connect, we ensure we change the gloves. That was the second thing I wanted to bring about. The third thing, we make sure we have air cultures done of our EP lab every month, because truly implanting these devices and then having an infection can be very uphill task. I always tell my fellows that remember, you are married to a patient, because he is going to hound you when he comes back with an infection and leave you with sleepless nights when he keeps coming back for dressings. So these are a couple of things. The fourth, so that we have a standardized care and a program, when the patient goes home, we hand him over after a device an instruction card. On that instruction card, we give him all the instructions that he has to follow after an implant in the acute scenario. Similarly, patients with heart failure, when they go back home, we give them an instruction card, which is about 3-page leaflet with a lot of pictorial assessment as to how is he to follow himself. So I think we have been handed over the stage by leaders like Dr. Khalilullah, further by Dr. Mohan Nair sir. Our life has been very simplistic, and we've been trying to only make it better. And I think forums like this, if we can send the message across, are the most splendid ones. So these are a few pointers which I wanted to share with the audience, what we follow in our EP lab.
Thank you so much, Dr. Padna. You very rightly mentioned that there is no distinction in corporate as well as private care and domain, because it's the human life ultimately with which we are dealing. But sadly, the reality in low and middle income economies is, ma'am, that when we are in a public sector setting, especially the more peripheral the setting, the greater is the compromise in the quality of care as well as in the patient safety. And that is what forums like this are striving for, ma'am, getting the teams from the periphery. And I'm very pleased to have teams from the district hospitals, teams across from the subdivisional hospitals, quality managers, and also people from South Asia who join on these forums regularly. Yes, ma'am.
Can I one point which is a distinction between corporate and a government hospital maybe today is that, yes, we do really worry and keep ourselves on safeguard as far as medical legal issues are concerned. So we always believe that everything should be documented and communicated, and that keeps happening in our head over and over again. Because at the end of the case, whatever you speak, you should always remember that there could be 5 hostile doctors sitting in front of you, asking you why and when you did that. So that's the only distinction probably I may carry in my heart today, which will soon be eroded, and even the government hospitals will soon have to follow that.
Thank you so much, ma'am, for adding that. I believe the accountability element, very, very important, which you have mentioned. And the center theme of quality is accountability. And that is something I think most of us are trying to inbuilt into the public health systems of this country. Thank you so much. Please stay over and for sharing your insights, ma'am. We now move to Dr. Vishal. Dr. Vishal, specifically, I would just be wanting to ask you, you have an extensive career of managing heart failure patients in Fortis Escorts Hospital, and you've also done your DM cardiology from GP Pant Hospital. And prior to that, you've been working in one of the top-notch institutions of this country. We would like to know from you that in your day-to-day clinical practice, you must have encountered many patient safety and quality concerns as you move through different settings. And currently, you are dealing with very critical patients who are often requiring implantable devices, heart failure patients, patients in acute LVF. So can you just recollect a couple of instances which really bothered you in terms of patient safety concerns, and how over the years or over the course of time your team has standardized these approaches and you've tried to minimize, like Professor Nair was saying, that his lab tries to achieve a 6 sigma type of error rate. So what has been your experience in this? We would like to hear your perspective. Over to you, Vishal.
Thank you, Dr. Vikram. It's been a pleasure listening to all these stalwarts here. In fact, Julie first made a great presentation about the processes and how it is imperative to patient care that everybody works in good interest and everybody works simultaneously. Then it was a great learning from Professor Khalilullah, and I had the pleasure of working with him and learned from him. So this has been a great journey. And Professor Nair was, of course, my teacher. So the things have become much more easier now. I must say that most of the things are standardized. Things were much more difficult and different when Professor Khalilullah was there. And he, over a period of time, these things have become a standard of care. So now there are two issues out of it. One is that as the things become more and more routine, complacency sets in. We tend to ignore few checkpoints, few things which we always used to do earlier, and that leads to problem. And second issue is that as the newer procedures which have not been done, they are much more complex, much more difficult. And then these procedures carry their own set of risks, which we don't know yet. So here, I must say that the most important thing is that every member of the team should be given equal importance, be it a nurse, be it a technician, be it a doctor, be it a junior resident. So in our lab, it is the most important thing. We just, like, I can give you one example, which is that of TAVI, which is a complex work where a lot of people are involved. And if 5 people are doing 5 different things, everybody has got a set of responsibility that he's responsible for that particular thing, and he has mastered that particular thing. So that means the chances of error are close to 0 if everybody is just concentrating on his work correctly and he is performing his task to the perfection. However, I'll give you an example that earlier we used to have these sick patients for heart failure. They used to come, and then while there was a crash, we used to have a lot of, everybody is running for the same thing. Once you ask epinephrine injection, there'll be 5 nurses scrambling around for those epi injections. And then you find that suddenly somebody who is responsible for something else is not doing that particular thing, but has gone to rush, for getting something else. So then we made it a protocol that this crash should be handled in a team manner. Everybody should be doing a particular job. One person should be responsible for airway, the other person should be responsible for circulation, heart rate, rhythm, and the other person should be responsible for those injectable medications securing the line. So then that way it is possible. And then comes the role of advanced devices like ECMO, which is now a part of the eCPR that we do. So, and the ECMO is a very complex machine, which is held somewhere in the hospital. You don't know where, you don't know whom to call at that particular time. And then the machine takes 10 minutes to prime itself. And then you lose those vital few minutes, which would have been very, very crucial for and a matter of life and death. So then we made a protocol that the ECMO team is in place, and as soon as a patient crashes and you think that patient is a candidate for ECMO, a ECMO number is there on which you can activate the ECMO team, and ECMO machine is primed and is placed at a designated place. This machine can be primed and kept in circulation for 15 days, and then you need to change the circuit. Of course, this is an expensive option because you waste a circuit if it's not being used. But that is very essential because it makes the difference of life or death to one of these patients. And we have lost few patients where we couldn't achieve the establishment of ECMO in time. So then we made a protocol, and now the ECMO machine is primed and ready, perfusionist on call, available, and you know which number to call and who will institute ECMO and who will have what role. So this is important thing is that not only achieving whatever you have thought, but also auditing as to what went wrong and how you can improve it. And Julie also highlighted this point in her talk, that it is extremely important that you just don't implement processes, but you also audit the results. And then you see that whatever this is a continuous evolving process. Quality is a daily learning. It's not as if you've achieved something and then you can't improve upon it. You keep on improving on it by just auditing and talking to each other and better communication, and by seeing that whatever you're doing is actually happening the way you want it to be. So it's been great. Thank you, Dr. Vikram. And I'm sure everybody will have a lot of things to carry from here while they reach back.
Thank you so much, Dr. Vishal, for sharing your perspective. You're very right in saying that good communication and clarity about the roles forms one of the essential components, as in neonatal ICU also. I, being a neonatologist, we very well can empathize that the moment the crash happens, in fact, if the roles are not very clearly defined, can result in a lot of haphazard and duplication of roles and wasting of the time. So the responsibilities, roles, protocolized management, as well as the response sequence of response. So that is one area, I think, which is a take-home message for the teams which are listening to you today. I think that is one way which you have standardized the response to an acute event. Thank you so much for sharing it, Dr. Vishal. So I'll request you to just hold on while we move to Dr. Mohit Gupta. So Dr. Mohit Gupta, my question to you is slightly different. I will like to ask you with a different twist, how you blend spirituality into clinical practice. And how do you think that in the stressful times of clinical practice of cardiology, spirituality can enhance the quality of care and patient safety? Well, we will ask you to speak from that perspective, and then I'll put another question to you.
Thank you so much for this opportunity. Thank you so much, sir, respected Karibullah sir, Mohan Nair sir, Vishal sir, and Dr. Poonam joining across the end. So many people. Thank you so much. So right at the outset, I would like to share two perspectives. The bottom line of the whole matter is that when things change inside you, things change around you. So quality and efficacy and safety is not about an outside matter. It's about our own thought process, that what kind of mindset that I'm going to lead in my life, And when I believe that my job is to treat the patient, I might be giving a very perfect and a good treatment to the patient. But when I believe that I am to heal the patient, I see myself as a healer, then the quality perspective is not just safety perspective, is not just about the outcomes, about the machines, about the devices, about the procedures and how successful we are, but it's also about the patient satisfaction. Unfortunately, what is happening today is that most of the doctors today, we are doing not a job which is better than a washerman is doing. The floor is getting dirty and nobody's bothered to switch off the tap. But a good safety and a quality outcome is that we also switch off the tap. That means we disallow the recurrence of the disease, such that the quality and the safety of the patient, his own psychological aspects are also taken care of. What are we doing for this? Lately, for last almost 7 to 8 years, besides the routine safety and efficacy outcomes, given a very limited setup, not a very powerful and a great infrastructure that a government setup would be having, what we have done is we have decentralized our safety and quality measurements. What we have done is we have recruited and formed small teams with 4 different WhatsApp groups. 4 different water scopes are on the basis of on the level of the faculty, then on the level of the junior faculty, then on the level of the technical staff, and then each group is specifically handling the instruments. What are their responsibilities that they're taking care of? That is also one of the group, and then directly concerning with the residents. How does it help? It helps us to have a more focused approach. Each one is having a very clear responsibility of the instruments, and they are also designated to see where are the lacunae that are holding, because this is a very common problem that we face. We have really problem with instruments, their repairs also, and sometimes it's very difficult for one person to do it. So everybody is doing that particular job, and when we form small teams, the outcomes are much better. The second part of this thing is that, how do we integrate these practices in our life? So there is a 4I phenomena that, we do it. And that first thing is the information that, like Julie gave a terrific information. And that is fantastic, that how each procedure needs to be carried on. But that is only information. The second thing is, if I inform you, you are aware of that, you need to be inspired. You need to be motivated to do it. I know about these facts, but unless I'm motivated to do it, and motivation can come only when you are educating both heart and mind. That is what we are doing. We are not just educating the mind, we are educating the heart, that you have to do it. You are responsible. You are not a doctor who is treating, you are also a healer. So they get into the process with their emotions, with their, what we call as an empathy. And when they are doing this, they're inspired. Once a person is inspired, all these safety outcomes, all these quality outcomes are then implemented into the practice. Each small team is making sure that they're implementing all the phenomena that Dr. Vishal, respected sir, Dr. Mohan Nair, sir, Julie, and my dear friend Dr. Aparna, they were highlighting. All these processes are then integrated. And once you are integrating all these things, you actually become an inspiration for others. So that is how you have to work. How does spirituality help us? Spirituality helps us only realizing that whatever you want to see outside, it has to first become created in my own mind. Very important. It has to be there. If I want to see my process, my thing, my patient happy, I have to create that thing in my mind. That is thinking from the end. We start thinking from the end, motivating the patient, talking to the patient, encouraging him not to create fear, but to create success in his life. So this is what we are doing. Every time we are motivating even the poorest of the patients that we are having. And that is what we do for each of the patients. And third thing, post-procedure. A good safety and a quality outcome is very important. It's just not about the completion of the procedure. You are good after implanting the device, but it's also meeting the patient equally with the same powerful vibrations as you met him before the procedure. That's the bottom line. Many of the patients are complaining repeatedly that my doctor is meeting me, the procedure has been done perfectly. But today's safety and quality outcomes are not about high-tech care. My dear friend, it is about high touch. It's all about high touch. How beautiful you are able to communicate with the patient. That is very, very important. When you are able to do a technology-based procedure, you are giving the best possible device. That's fine. You made him into a robot, a machine. But what about your communication? You have to take out that fear out of the patient that you are fine now. And for that, we run a holistic meditation program. We have a beautiful dedicated yoga clinic that we call it as a 3-dimensional heart care program, in which we are stressing 3 aspects of our life: diet, exercise, and rest. These must need to be incorporated programs today in all the safety and the quality outcomes. So procedure is one thing, that is very, very important. A great operator will be able to do a great procedure, but a great doctor, a great human being will be able to heal the patient, and patient will actually, you will see the recurrences are much less. So this is my take on that. I sure would not be in a wise position to add on the data that Julie has given and many other people have given, because they're much powerful and much beautiful setups. But definitely one thing that we have added on in our setup is this particular thing. So these are my thoughts on.
Thank you so much, Professor Mohit Gupta. In fact, I think being a spiritually, awakened individual, Professor Gupta could read my mind. In fact, he answered my second question before I even posted to him. So I was going to ask Professor Gupta how exactly he has incorporated this into training his students at the GB Pant Postgraduate Institute. So Professor Gupta, I think you answered that beautifully, how you have inculcated the holistic healing process into preventing the recurrence rates, and also I would say awakening the agency of your teams, because unless and until the agency is awakened, the quality first has to come from within, and it is only then that we can become healers. You're very right in saying that. Dr. Gupta, you are unmute. You have to unmute yourself, please.
The only thing that I want to again say is that, nothing is going to change until unless we change. We make policies, we make, different kind of meetings we have, but each one has to take the responsibility of the change. And once we are able to do that, change is automatically going to happen. The problem lies that we always feel more comfortable in allowing others to change. That is never going to happen. The change has to be first in me. If I'm able to change myself, the change will automatically manifest in the world. So this is how the things work in every aspect of life, and quality and safety outcomes, I feel that they are no different at all.
Thank you so much, Professor Gupta, for giving those insights. I think valuable words. The change has to first come from within for us to involve and scale it up into quality into our systems. So with this, I would now come to some comments from Dr. Poonam Gupta. Dr. Poonam Gupta, your perspective on this session, and then we have a question coming from one of the governing board members. That question is for Professor Mohan Nair, sir. So we will just put the question subsequent to Dr. Gupta's comments. So Dr. Gupta, you are a quality improvement person. You are the lead of the quality improvement in cardiac clinical services at the Qatar Doha Hospital. And what's your perspective on, you heard the most eminent cardiologist of the country sitting and sharing their perspective on the evolution from Professor M. Khalilullah, sir, the various aspects of clinical cardiac care in India. And you have done your undergrad in India, and then you moved to a different nation, and you're looking at quality improvement from an international perspective. So what are your thought processes on this, and any thought processes you would like to share with the panel as well as the audience?
Yeah, so first of all, thank you so much, Dr. Vikram, for inviting me to this session. So it was such a, I did get some great insights from all of you. That's I couldn't even take my eyes off from the screen and just listening to everything. So first of all, thank you so much, Julie. It was an excellent presentation. And I'm deeply touched by everything what's being explained by all of you, Dr. Mohan, Dr. Professors and all. The most important thing what touched to me more, it's about person-centered care. Like we are treating the patients and we are improving quality and safety, but as well as we are looking the patient as a perspective of person, like we are touching their lives and all. So that's really I'm taking so many lessons from this session, and definitely I'm going to apply some of these in my facility here as well. So I don't have anything to add, because all of you are highly expert, and I don't have anything especially, but I'm taking a lot of learning from this session. So thank you so much for inviting me on this panel, Doctor. Thank you.
Thank you so much, Dr. Poonam. I next come to the question which Dr. Prabha Ranjan wanted to pose to Dr. Mohan Nair. Dr. Prabha, can you unmute yourself, please, and ask your question? So, sir, by the time Prabha unmutes a question, I will just read out the question for you, sir. I think she's having some internet connection issues. So Dr. Prabha wants, yeah, so Dr. Prabha is there. Yeah, Dr. Prabha, please unmute yourself and ask your question to Julie and Professor Nair. Yeah. Prabha, there is some audio issue at your end. Can you just unmute yourself, please? Okay, so Prabha, I think I'll just read out your question if you give me that privilege. So, sir, Prabha wants to ask, she says that Prabha is an obstetrician. She's a governing board member with NQOCN, sir. She's one of the founding members of the organization, does great work in quality improvement. She wants to ask, as an obstetrician, how can we contribute in delivering quality care when we refer a pregnant woman with cardiac problem to a cardiologist? what specific things we should keep in mind before referring to the cardiologist? Sir, a pregnant women with cardiac problem.
See, that's a very nice and important question. And we do have, of course, as you know, Holy Family started as a mother and child center, and we do have a lot of patients. And most of them are now trained to refer at the right time. Now, you would like to refer a patient, one, if the most important is if there is breathlessness that is beyond, some amount of breathlessness is expected during pregnancy. Some of it can be correlated to the hemoglobin, which can be checked by the gynecologist. We don't need to know. But the moment there is a doubt, especially if you have a cardiologist on board, I think they should refer, because it's amazing how patients who look and also claim to be reasonably well have peripartum cardiomyopathy, for example. We used to have a lot of referrals for pregnancy-induced hypertension, but with the availability of labetalol, that has come down. The other issue that, and that's my own kind of personal experience, a lot of people need not agree with this, is patients with arrhythmias, for example, SVTs. What happens, for some reason, SVTs get exaggerated during pregnancy. They have incessant, almost incessant SVT. And over the years, we found that none of the calcium channel blockers, neither calcium channel blockers nor beta blockers decrease the frequency. And almost all the patients in whom we stepped up beta blockers or calcium channel blockers, in fact, I would say all patients, we lost the child, either because of uterine inertia or intrauterine growth retardation, because of the amount of beta blockers we are giving. So what protocol that we use, and it might surprise you, some of you, but the only time when we have got good outcome is when the patient comes in with an SVT. They are trained, and whenever the moment the SVT starts, they come in, and at that time we convert it with an intravenous agent. So that decreases the need to use calcium channel blockers or beta blockers in the interval. The patient might have one episode in 2 months, but if you're putting them on oral, like in the regular patient with SVT, they're taking these drugs unnecessarily. I mean, it's just a preventive, and it doesn't seem to prevent. So that's something that I have learned from experience. So these are the 3 or 4 things, and we feel that in peripartum cardiomyopathy, arrhythmias, and in some cases of resistant hypertension, we are able to help. Most other things, I think the obstetricians of today are well trained to handle. But I think that the senior obstetricians in our hospital, or the ones who are good, keep us in the loop, just because, like as Julie's slide said, if there's a comorbidity, then you don't wait for it to escalate. Even if it is a minus level, you get the other team into the loop. Tell them that we have a patient here and we might need your help anytime. So all the patients who have even previous history of heart disease, mild heart disease, even with successful pregnancies, when they come into us with a new pregnancy, we are put on the loop. So that helps to, again, it's a question of teamwork. We can plan when to admit, and when they get admitted, we know when to go. We know how frequently to do an echocardiogram to see what's happening. We know what to tell the patient. The parents are extremely naturally very apprehensive. So we can tell them that, okay, this is something we can handle. Nothing is going to happen. But this is something which should do well, but we can't be sure. And the third is that this is certainly a disaster, and it might be, if it is on time, it is better to end the pregnancy and save the child, save the mother. So these are some things which we have, learned, and I'm sure Vikram knows more about it than I do. But I hope that at least I have been on the same frequency as the question. The answer sometimes is not on the same frequency. So this is I hope it is on the same frequency.
Thank you so much, sir. In fact, you being quite humble on that, I should admit it here. And in fact, you've answered it. And for the purpose, there are a lot of maternal neonatal health teams which are here. And it's very rightly mentioned that there should be timely referral, early identification, and keeping the patient in the loop. So because of want of time, one last question to Julie. In fact, it's not a question, it's an observation. And it's been mentioned by Kamini Rawat. She says, very appreciable presentations. I mean, definitely we'll put it on our day-to-day practice. Good points which she has noticed is that nurses should talk 15 minutes with each patient 2 times in every shift. Really a new glance at our practice. So I would just like to ask you, it really makes me inquisitive. I know that it's good to have good communication skills, openness, and transparency in your communication. But considering that you have so many duties and we have resource limitations, and we often have patients at different levels of communication, understanding, and the skill mismatch may be there. The understanding as well as the dialect skills, they may be mismatching. So how in your hospital you have established the process of good communication? So are there some, cheat sheet points, or I would say some key tips you'd like to give to the nursing teams who are here, how to improve their communication even when they are stressed at the end of the shift, tired, they just, had a patient who had crashed and they're just moving out of it. They have not eaten their lunch. They're probably tired and there's some issues back home bothering them. In midst of this, how do you still maintain a calm demeanor and, you engage in meaningful communication? We know communication helps, but your tips, how do you improve the communication with the new entrants as well as the new patients?
Thank you, sir, for asking me this question. I believe that whatever situation we are handling, we should be calm and quiet. Whenever the patient comes, because of the better communication skill only, we will be able to understand what pain they are suffering. So we are the one who are exactly dealing with them, being with them together, means we can only understand what exactly they are suffering. So according to that only we can deal the problem. We can inform the doctors what they are going through. And I think half of the diseases are being cured because of our good communication and our interaction with the patient. Even though we are not giving any medicines, at least when we are talking to them, we are trying to take out their exact problems which they are facing. So I think if we are dealing with any of the hardships, we should forget all those things and try to deal with the patients in a very good manner. And in our hospital, each and every nurses, if they are not even good in some of the languages, they try to tell others, those who are very good at the language which the patient is able to communicate, so that we can help them and deal their tough situations. So like this, we are handling the patient.
So thank you so much, Julie. I think that sums
I
up.
must add
Yeah,
that,
Professor Nair, sir, please go ahead.
we do all the hard work in the procedure, but 9 out of 10 cases, the doctor calls me and tells me, please thank the wonderful nurses that you have at Holy Family. So I think it's also a culture, and they do actually communicate a lot. They, over a period of time, become almost like family members. So, in fact, I feel envious sometimes. I thought I did the procedure, but they want to meet Julie, or they want an appointment with Julie. So,
yeah, sir, you're very right, sir. I think Shatrughan has also mentioned that, in fact, communicating with the patients is very, very important to get a feedback about the existing quality and their concerns and their side of the story. So I think it's very, very important that ask me three, or what basically the patient is concerned. Our perspective and their perspectives may sometimes be very different. Nurses, I think, like Julie has very rightly mentioned, spend most of the time with the patients, and they can break those barriers of language, even with the beautiful illustration like interpreter you said, that some of the nurses not being very familiar with North Indian language. So thank you.
Exchange.
Yeah.
They exchange. We don't need an interpreter, and the one who is good exchanges with somebody who is.
So with this, sir, I know there is a lot of, Julie, you wanted to add something?
We have multilingual nurses working with us.
Great. So, so thank you so much. I think due to want of time, sir, if you permit me, Khalilullah, sir, we would like to be concluding this session today. And we look forward to having more engrossing sessions with the cardiology teams across the country. WHO regional advisor asked me when we put up this topic, how does it fit into the agenda of the maternal and neonatal health domains of the country? So we felt, sir, that the Lancet Quality Commission picks up cardiac critical care as one of the areas which requires a lot of quality and patient safety, addressing it at the level of the top cardiologists of the country, which we are very pleased, thanks to Professor Mohan Nair, sir, Dr. Khalilullah, sir, getting all the eminent teams here on one platform. I think it's a great start, sir, but we would not like this to be a one-off event. And the point, there are two short things which I would like to mention, how this communities of practice can continue to engage with the cardiology teams and help to spread this message and this platform of quality improvement across. One is, sir, that with the support of WHO South Asia and UNICEF India Country Office, we are organizing, sir, WHO certified courses on point of care quality improvement. These are 2-day courses, sir, which are done in a workshop mode. And the next course is due on 11th and 12th. And the next month, this month, we are doing 2 courses. The next month is 25th and 26th of September. Dr. Sonam will be sharing the links into the chat box. And these are the workshops which we can register free of cost. Our clinical nursing teams, our doctors can register and get certified. And this will help them in gaining a greater perspective about the point of care quality improvement methodology. Now, this is a methodology which Government of India is using for the labor room quality improvement methods. And it is also using it across the NQOCN, National Quality Assurance System. We are using it to improve the quality of care within the existing resources by process reorganization, doing the root cause analysis, developing change ideas, plan, do, study, act cycles, etc. So I think it would be very meaningful for the cardiology teams if they can join this with the link. We will be mailing the link separately to all the people who have joined this session, and they can enroll for any of these 2 sessions. So this is the first way. The second thing is, sir, that NQOCN also publishes the BMJ South Asia Open Quality Journal, which is an exclusive issue for South Asia, which showcases the improvement and the patient safety stories from South Asia region, and the main chunk is from India. Now we are requesting for call for papers for the second edition. The first edition just came out in July this year. And the best part about this is that there are no article processing charges. And we also provide some mentoring across, for teams which require mentoring to document their improvement story. NQOCN will provide a mentor to document this, work with the teams, and to analyze the data, write it in the style of BMJ, and this will all be done free of cost. And this is with the support of UNICEF India, sir. The entire 1,500 pounds or the 1,350 euros, which is the charge of article processing charges, is waived off. And this is a journal. And for the second issue, as and when the articles are accepted, they will be going up online. So the first issue is up on the BMJ website. You all requested to visit the BMJ Open Quality and look at the first issue. It has got 20 state-of-art articles, all from the Indian subcontinent. So please, if you have some improvement story, especially in the field of cardiology, I'd request the teams to please submit for this, and also to spread the word about the point of care quality improvement workshops and get trained in quality improvement and continue this meaningful dialogue. And let's engage as a larger fraternity which believes in patient safety and quality. So with that, thank you so much. It has indeed been an honor and a dream come true to have all the stalwarts here. Yeah, Mohan Nair, sir, please. Concluding remarks from you, sir. Please go ahead.
No, I was just saying that while this is true, we can, if somebody is interested, and we've had people, you can have a quality lead from your hospital, which may be not at the same level as Holy Family in terms of communication. And I especially selected Julie because we are talking of the care part of it. Just like Mohit said, it's the healing or care. So if anybody wants to come to Holy Family, they're more than welcome. They can just send us, we have a large footfall, and we have very good instructors, and they can just send me a CV, and I will try my best to see that, they go through. And of course, for cardiology itself, we have had trainees coming from all over South Asia. The same way, that's for procedures. But for the care part, I think you can initiate. And that would also, be a good step forward.
Thank you so much, sir. I think for offering your facility as one of the training sites. In fact, we would publicize it with the active consultation with you. And thank you so much for announcing it on the forum. I think NQOCN will be actively in touch with both of you to take this forward and this collaboration, so that the good practices are shared and they go across the various teams of the country, and we don't reinvent the wheel. In fact, the things which interested us most was the zero infection rate over the last 6 years. So that is in fact commendable. And we would like to know more, and maybe one of the communities of practice session, we would like to hear more in detail about how exactly the journey was. So Khalilullah sir, one last word from you, sir, and your blessings for this entire event before we sign off, sir.
Vikram, I must appreciate the way you conducted the symposium. It's absolutely splendid. I have not attended many symposia like this, in which you will solely sit so organized and wonderful. Give a big hand to Dr. Vikram.
Thank you so much, sir. Thank you so much, sir. In fact,
and also to Julie for that.
Yes,
yeah, definitely, sir. And thank you so much. So over to, we have a next session which is coming up. We are going to be talking on 14th of this month with the Canadian Neonatal Networks. We have got Dr. Prakash Shah, who is a professor of pediatrics at Toronto University. Sir is going to be talking about the Canadian International Neonatal Networks and how is spearheading the quality movement across the European countries with the Canadian Neonatal Network. We will be posting the details of that session, which is coming up. And looking forward to seeing all of you again and an active engagement. And welcome to the cardiology teams again. And I believe the NQOCN family is now growing with WHO and UNICEF and Government of India. And I also acknowledge the presence of Dr. Dinesh Baswal. Sir was a Joint Commissioner and in charge of the maternal health at Ministry of Health and Family Welfare. And he's been the proponent of the Lakshya program, that is the Labor Room Quality Improvement Initiative. So thank you so much for being there, Dr. Baswal, sir, and all of you. And of course, to all the participants and NQOCN office, stay safe. Good night, everyone. And sorry, the session extended beyond the time, but I'm sure it was very useful for all of us and deeply thrilled to have all of you. Thank you so much. Good night.
Bye. Very well.